Good morning, everyone.
Good morning.
Welcome to Know and Go Friday. I'm Doug Trost. I'm the president and CEO of St. Francis Home, and I'm filling in for Holly Brenner this morning. We're excited to welcome you to what promises to be a very informative session this morning. To those of you who are joining us for the first time, welcome. And to those of you who are back for another session, welcome back and thank you. We are very appreciative that you've all joined us this morning. Before we begin, I would like to share a reflection. And this is titled, Is Happiness Around the Corner? For lots of people, happiness is just around the corner. They just need to get their degree, a particular job, a promotion, or a raise. Maybe they're waiting to get married or have a child. Perhaps they will be happy when they retire. Alfred D. Souza said, "For a long time it seemed to me that life was about to begin, but there was always some obstacle in the way, something to be gotten through first, some unfinished business, time still to be served, or a debt to be paid. Then life would begin. At last it dawned on me that these obstacles were my life." John Lennon put it another way, "Life is what happens while you are making other plans." The point is our lives are happening now. If we are to get the satisfaction and fulfillment we want, we have to learn to draw pleasure and joy from everything that happens to us and around us, because these experiences are the very essence of our life. The more aware we are that life consists of the journey, not the destination, the more likely we are to get the most out of it. So if there are things you want to do, begin to fit them in now, or accept the fact that you can be happy whether or not you do them. Happiness isn't just around the corner, it's now or never. The good news is that you have everything you need to be happy. Philosophers, poets, and scientists all agree it can't be attained through money, prestige, or power. Happiness is not a fact, it's a mindset. All you need is optimism and gratitude. I have just a few housekeeping things. First of all, we have our associates from Ripon and Waupun via video conference. Looks like there's a couple of people there. Good morning. And then on your table in front of you, just a few things. There's a flyer regarding next month's Know and Go. Join Agnesian HealthCare physical, occupational, and speech therapists, as well as athletic trainers, to learn more about our comprehensive therapies. So we hope you join us for that. There's a yellow comment card. Please fill that out. That helps us a lot with putting together the Know and Go sessions. Then we have a green slip. If you're interested in receiving credit for being here this morning, and if you're interested in a chance to win veggie bucks, please fill this out, turn it in. We'll pick these up towards the end of the session. And then, if you weren't here last month, we have some really nice mouse pads. They're up front here in the basket. I took mine back to the office and everybody was very, very jealous, so grab one of those. Now it's my pleasure to introduce our speakers. We have with us Dr. Strong. He's a family physician with Agnesian HealthCare who has a special interest in geriatrics. He serves a wide variety of populations within our community and has been practicing medicine for over 30 years. He is the medical director at St. Francis Home and Villa Loretto in Mount Calvary. Dr. Strong has a deep understanding of how to ensure individuals who suffer from dementia are cared for in the most appropriate way with the highest quality of life. He has the personal experience of being the guardian for his father, also a physician, who had a long journey with Alzheimer's disease. We also have with us Deanna Taplin, who is the Director of Health Services at St. Francis Home. She has worked in long-term care for over 30 years, serving as a Director of Nursing for over 14 of those years. She came to St. Francis Home in 2012 and has since then been instrumental in educating and bringing awareness to St. Francis Home associates on how to improve the lives of those we serve. Jenna Floberg. Jenna is the Assistant Administrator of St. Francis Home and has worked for us for 3 years. She has helped to engage associates in various dementia initiatives throughout her campus, and has also helped in educating and bringing awareness to St. Francis Home Associates on dementia care. Dr. Strong, it's all yours.
Thank you. I'd also like to welcome you to this session of Know and Go. Hopefully by the time our session is completed, you'll know a little bit more about dementia and Alzheimer's disease. You can go and use that information in your interaction with others and family. Perhaps you have a family member yourself who is affected by Alzheimer's. Perhaps you're wondering about your mom and dad with what happens as they get older. Perhaps you misplaced your car keys last night and are wondering if that's a sign of something. Maybe you're here just for the mouse pad, but anyway, glad to have you here, and welcome to those who are at our remote sites as well. Our basic outline for today's presentation, I'd like to talk a little bit about why Alzheimer's is an important issue for us in our society going forward. Talk somewhat about what's happening inside the brain in people with Alzheimer's, some of the science. Talk about who's at risk. Talk about how Alzheimer's or other dementia is diagnosed. A little bit about what treatment is available in 2015, and what we could do possibly to help prevent dementia going forward. And then lastly, we'll hear from representatives from St. Francis about a program they have about building empathy for patients with dementia via their virtual dementia training.
Dr. Strong, I don't think your mic is on, which I think we can hear you, but then the people in other places can't.
There, I think it's working now. At least can you hear me better?
Sure.
Light is on. Do you want me to use the hand phone?
It's, now the people at the offsites can hear though, okay?
Oh, through the...
This is just for the people in the room.
Carry on, Mike.
Okay.
My apologies for interrupting.
If you do have trouble hearing me, raise your hand or something. I'll try to speak up even louder. Okay. First, we want to talk about what is dementia. Dementia is a term used to describe a number of conditions characterized typically by memory loss as well as dysfunction of other thinking skills. And these problems affect a person's ability to do everyday activities. So dementia is a very broad term, and it encompasses many different diseases that lead to this particular outcome of typically impaired memory and impaired thinking. The impaired thinking may involve more than memory. It may involve language skills, social skills, the ability to perceive things correctly in our environment. Alzheimer's disease is one particular cause of dementia. It happens to be the most common cause, and it's one we're most familiar with. There are other causes of dementia, and these are some of the more common. The number 2 cause for dementia is called vascular dementia. Vascular is a term meaning blood vessels, and that type of dementia is caused by multiple strokes. These may be overt strokes that a person is aware of and has occurred over time, but they also may be very tiny strokes that occur on a very subclinical basis, that occur without a person even being aware. A second type of dementia that is in the top 4 or 5 causes is something called Lewy body dementia. People with this have a little different brain pathology than Alzheimer's dementia. They also present differently. They often have problems with maintaining alertness and awakeness, much more than Alzheimer's patients do. Frontotemporal dementia is a dementia that involves the frontal lobes of the brain and often is characterized by behavioral disturbances. Parkinson's disease, you've heard of Parkinson's disease with the movement disorder that's associated with that. People who have Parkinson's, if they have it long enough, typically do develop dementia. Substance-induced dementia, alcohol. Alcohol can lead to dementia. Other substances can do that as well. Something called prion disease. Maybe you've never heard of that, but there's a disease called Creutzfeldt-Jakob disease, which is caused by a prion. A prion is an abnormal protein, acts sort of like a virus. It's a rare cause of dementia. but gives you some idea of the breadth of things that can cause this problem. And then lastly, I mentioned mixed dementia. Many people will have more than one cause. We know that if we do brain biopsies on people that have died of dementia and look carefully at the pathology, many of them will have more than one type of dementia evident. The most common mixed cause would be a combination of Alzheimer's and vascular dementia. Why is this important? As we are all getting older in our society, we have the baby boomers that are beginning to age, and as they get into their 70s and 80s, we're going to see a dramatic rise in Alzheimer's disease. Currently, it's estimated in the United States we have about 5.3 million people. By the year 2050, they're estimating 13.8 million. So a dramatic increase just based on the aging of our population. This is an expensive thing to take care of. Direct costs right now in the United States, $226 billion, and it's estimated by 2050, $1.1 trillion. The reason for the expense is that many people, as they reach the advanced stages of Alzheimer's, need advanced care. They need assisted living. They need in-home caregivers. They need nursing home care. The median cost of private paid nursing home care in the United States right now is about $90,000 per year. And Medicare does not pay for nursing home care for dementia. So that means people pay for that out of their own pockets until their money runs out, basically, for many of them. So a very expensive undertaking. And as a society, people are looking ahead to say, well, what can we do to try to head off some of these expenses? Like many chronic diseases, there are risk factors for this, and in Alzheimer's it's no different. The number one risk factor is age. And I'll jump ahead here to this slide to show the prevalence of Alzheimer's disease by age. And you'll see that particularly once we get into the late 70s and certainly into the 80s, the prevalence rises rather dramatically. And people, as they get into their 70s, really begin to worry about their memory. Very common concern, often in the doctor's office, forgetting this, forgot that, is this the earliest stage of Alzheimer's? And because of those concerns, we're actually diagnosing Alzheimer's earlier now than we did in the past. Gender, it turns out women have more Alzheimer's disease than men, by a ratio almost 2 to 1. Genetics, talk about that in just a minute, but certainly if you have a family history of Alzheimer's disease, you are at increased risk yourself. Diabetes is a risk factor for also Alzheimer's disease. Elevated cholesterol, things that impact your heart health make a difference. And then major head injury is also considered a risk factor. A head injury that led to loss of consciousness is a risk factor for subsequent development of dementia. Talked about that. Genetic factors. I mentioned that family history is important, but we know even more information than that, and that is that there's a particular gene called the ApoE gene that is closely related to the development of Alzheimer's disease. And people who have this particular gene have about a 10 times increased risk of developing Alzheimer's. That's a test that can be done on blood. However, people who have the gene aren't necessarily going to get Alzheimer's. In fact, it's just a risk factor. There's some controversy about whether to do testing for ApoE. One study looked at one group of people that was tested and was told results of their ApoE, and another that was tested but not told results. And the people that were positive for ApoE and were told results actually ended up doing worse functionally than those that didn't know. So maybe knowing the knowledge that you have ApoE makes some difference with how ultimately things turn out. So ApoE testing is not a routine part of what we do. I'd like to talk a little bit about the brain and what happens in Alzheimer's. This is a picture of the brain. We have these folds which are called gyri, and the bulges, and then the grooves are called sulci, and they, the brain weighs about 4 pounds or so, and within the brain we have nerve cells, they're called neurons. There are about 30 billion neurons in the brain, and each neuron has about 1,000 connections to other nerve cells. So there's a really extensive network within our brain. The nerve cells communicate with one another via chemicals called neurotransmitters. We have various kinds of neurotransmitters. We know in Alzheimer's there's a relative lack of a neurotransmitter called acetylcholine. We have different lobes for the different structures. The temporal lobe is sort of on the side, that's the green, and that is involved with speech, and also is an important area for Alzheimer's. We'll talk about that in a little further. The occipital lobe is involved in where the visual cortex is identified. It's involved with vision. Parietal lobe has a lot to do with our motor activities, ability to move and carry out our motor activities. Frontal lobe is involved with personality and also with long-term memory. Cerebellum, the purple, is involved with coordination and movement. And the brainstem acts as a conduit for transmitting signals from one part of the brain to the other and down to the spinal cord. Turns out that we have different kinds of memory, and these different areas of memory are mediated by different areas of the brain. The problem in Alzheimer's disease has to do with something called episodic memory, which relates to remembering a particular event and what happened at that time. So remembering where we parked the car, what we did last Saturday on our day off. We have other types of memory that are found in other areas of the brain. For example, we have what's called procedural memory. So we remember how to ride a bike or how to shoot a basketball. And that is often mediated more in the parietal lobe, different area of the brain. So when we talk about memory loss, particularly in Alzheimer's, it may be just a particular kind of memory loss. And it's kind of interesting that sometimes we'll see in the Alzheimer's patient, they may not remember what happened yesterday, but they can use a golf putter just fine, they can fold clothing, they can play ping pong. So their procedural memory may be intact for a period of time, but their episodic memory is not. So what happens with, first of all, a little bit about normal aging. As we get older, we all do lose a little memory. Our speed of verbal memory actually peaks at age 25. And our gray matter, which is one component of the brain, is greatest in terms of volume by age 29 or so. Then overall, we begin to sort of age physiologically in total at about age 29. So we're all probably headed on the downhill slope here. But in Alzheimer's, there's a process that happens. Like many chronic diseases, there's changes take place that we are even unaware of, where there's no symptoms at all. And then these changes begin to produce some symptoms, and then they lead to a loss of function. And the basic process in Alzheimer's disease is that our body develops some abnormal proteins in the brain. And this begins probably in the 50s or so, 40s for some people. The abnormal proteins have special names. They're called beta amyloid and something called tau, T-A-U. And they accumulate in the nerve cells over time. And we can actually test for these proteins before a person has symptoms. We can do cerebral spinal fluid studies or special brain imaging studies to try to identify the proteins. And then they begin to exert their effect by causing some nerve cells to begin to die. And at first, we have plenty of reserve there, we don't miss them. But before long, as the nerve cells begin to die further, we begin to see some symptoms. And then, to truly call it dementia, we have loss of function. We start to see persons not able to carry out their activities of daily life. This is a picture of MRI looking at the brain. And these pictures show on the left a person who's 70 years old that is normal. In the middle is someone that has the earliest stages of Alzheimer's called mild cognitive impairment. And then on the right is a person with Alzheimer's. And this is a picture taken as if a slice is taken from the top of the head down toward the neck. See if we get my pointer to work here. We have, of course, the bony skull out here, on the outside. You can see the brain substance, these little grooves, and the brain itself. And then we have cavities within the brain that are filled with fluid. And the first thing I'll mention is that this fluid-filled cavity here, you'll notice gets larger as we progress. And that is due to what's called brain atrophy. The brain does get smaller. And you'll notice, too, that just the volume of the brain tissue here is much less than you see over here. And in Alzheimer's, there's a particular change in the brain that takes place in an area called the hippocampus. The hippocampus is located right in this area here on each side. It's on the inside aspect of the temporal lobe. And that is particularly important because the hippocampus plays a big role in the formation of new memory. Think of it like the file clerk for our brain. So we have information that comes in. The hippocampus acts as a file clerk to put that information into other areas of the brain that form memories. And so Alzheimer's has a predilection to this area here. And you'll see that, again, the black area represents fluid, or areas that, where that tissue has smaller or shrunk compared to here and here. And often in the evaluation of someone with dementia, we are doing MRI scans. So this depicts the process of what's happening with Alzheimer's. On the left axis, you'll see what's called cognitive function. That means memory, how well we relate to others, how our language skills are. And across the top, you'll see that as we age, we all have a little drop in memory. And it's a common concern is what's normal aging and what isn't. But you'll notice that normal aging doesn't really lead to a loss of function. We're still able to do what we need to do. We can carry it. We can use the restroom. We can keep ourselves clean. We can use the telephone. We can pay our bills. But Alzheimer's then has this preclinical stage where these changes in the brain, the protein, are occurring, and then that leads to a decline in function over years. And we reach a point here which researchers have called mild cognitive impairment. A new term for that is mild neurocognitive impairment, where a person begins to show some signs that their memory isn't what it should be. And we can do some tests of memory, and we can compare that to normal aging, and we start to see that there's a problem. And then dementia occurs here when that memory impairment is so severe that it's beginning to affect, again, function. That whole process may take 20 years to occur. So it's a little bit like many other chronic diseases. We have people that are predisposed to it. There are certain risk factors. We know that environmental influences play a role with it. And then a person begins to actually show signs of impairment. Think of it like, for example, chronic obstructive pulmonary disease. We have people that are predisposed to that. If they smoke, they're more likely to get it. They have some reserve in their lungs, where even though their lungs are not are gradually being destroyed, they don't notice any shortness of breath. But eventually, so much lung tissue is lost, they're now short of breath, and eventually that lung may actually fail. So it's a similar sort of model for Alzheimer's disease. This is just a gross picture of showing that atrophy that I talked about, where the brain actually does look smaller. The space between the brain tissue is larger. You can just this tissue is more vigorous. So how do we diagnose Alzheimer's? The most important element is the history, and it's important to get history from someone who knows the patient. One study suggested that if the patient comes in complaining of memory loss, it's more likely that they have something like depression, where their thinking isn't quite what it should be. But if someone else complains about memory loss in a loved one, pretty significant, and that's a strong predictor that something harmful is going on. So if your spouse is saying, you know, honey, you're starting to lose a little bit here, maybe it's time to get that looked into. We do tests of memory, and as part of the wellness exam for Medicare, it's now required that we do a cognitive screen. There are various ways of doing that, but there's some very simple things. For example, asking a person to name as many animals as they can in 1 minute is a commonly used test that I employ in the clinic. So, okay, you got a minute, tell me how many animals you can think of. And surprisingly, that little test is a pretty good screen for memory problems. And if you can remember more than 15 animals in a minute, that's our cutoff. You're doing okay, but if it's less than that, it's time for more testing. Another simple test, we ask a person to simply draw the face of a clock, put the numbers on it, and then put the hands on the clock for the time. And that little exercise forces them to plan ahead where they can put the numbers, and have the ability to write it down and then put the hands in the correct position. It's called the draw a clock test, and also is valuable for screening. Beyond that, we often do a test called a mini mental status exam, and this is not a real good screening test, but it's a good test to tell how a person's doing overall. And there's very simple things. We ask a person to, well, what is the date? Where are we right now? What state do we live in? And then we ask them to remember 3 names, three objects: ball, car, and man. And in a minute, I'll ask you again what those are. We ask them to repeat the word, spell the word world backwards. We ask them to subtract 7 from 100 and do that serially. So beginning 100, subtract backwards by 7. Then we ask them to repeat those 3 words. It's a measure of their short-term memory. We may ask them to name some simple objects, write a sentence, copy a diagram. And those response to all of those various questions adds up to a score, and that's something that can be used to follow a person along as they progress. We do a neurological exam, mainly looking for other things. We don't see abnormal reflex typically, or weakness or incoordination with early Alzheimer's, so the neurological exam, other than the mental status exam, is usually quite normal. Lab tests, there's some basic lab tests that are done to look for anything that might be causing memory problems. So vitamin B12 level, a thyroid test, sometimes a HIV test, because that can lead to dementia. Syphilis in its latest stages can cause dementia. So there's some limited laboratory tests that are done. And then often imaging. MRI is the most commonly used test. Not everyone needs an MRI, but and we mainly do the MRI looking for other things. We're often looking for little strokes that we didn't know about. And so MRI is commonly done in the dementia workup. Some of the things we ask about in the history, of course, forgetfulness, inability to learn new information, and that's a common symptom of Alzheimer's. Difficulty managing finances, planning meals, or taking medicines on schedule. Those are kind of the manifestations. And that has implications for control of their other medical problems. If they cannot remember when to take their medications, we're going to see problems in managing their other problems. Getting lost going to familiar places. So person that's driving and always knew how to get to the cabin up north, but now is having trouble.